Just a slight disclaimer, there are some gory photos in here, all of which I've pulled from the internet. I haven't taken any photos from actual NUH patients here because I didn't have their consent to do that. So I'm going to start off by taking you through what the NUH burns unit actually does. We'll look at who gets burned and how, and then we'll look at one of the main areas for the on-call team, especially at the QMC site, which is in assessing for the possibility of inhalational injury. We'll then look at the initial burns assessment and resuscitation, the initial trips to theatre, back into critical care, we'll touch on that, coming back to theatre, and the rehabilitation and outpatient work that the burns team do. So we are a burns unit in Nottingham, we're not a burns centre. The main centre for the Midlands is in the QE in Birmingham, and they take all ages of patients and all severities of burn. In Nottingham, we're very happy to have adult patients with up to 25% total body surface area injuries. Above 25%, there is an obligation on us to discuss the case with Birmingham. But they are usually quite relaxed about us hanging on to these patients. Up to 40% with deep dermal or full thickness injury with an inhalational injury, and up to 50% if they do not have an inhalational injury. Now that's a slight derogation from national guidelines, but this is testament to the incredible work that's been done by the Nottingham Burns MDT over the years, and the Midlands Burn Network are quite happy with this. There are some burns facilities within the region as well. They're based in Leicester, Coventry and Stoke-on-Trent. They're also part of our network. It takes small and non-complex burns. So what's a complex burn? Well, it's all of these things. And as you can see from that list, it basically means that anything that's coming into Stoke-on-Trent, Coventry or Leicester is probably going to go to the QE or Nottingham at very least in the first instance. Who gets burned? Well, the classic risk factors for major burns are patients who drink alcohol to excess, who use illicit drugs or abuse prescription medication, smokers, those subject to socio-economic deprivation. Unfortunately, we see a lot of self-harm coming through, so patients with significant mental health diagnoses, and also criminality, either as the primary intent with the burn or as an attempt to cover up some other form of criminality. How do they get burned? Well, the vast majority are thermal, although we have seen quite a few chemical burns as well. Some of the deliberate self-harm burns we see are chemical in nature. We have had a little run of electrical burns recently, thankfully relatively minor ones, and thankfully we almost never see radiation burns. But as you can tell from this, history is vital. The thermal burns include cold injuries, and the hand there at the bottom right is a classic thermal burn with some full and partial thickness injury, the full thickness injury being the pale, leathery looking areas of skin there. Chemical burns, big implication for the patient, but also for the staff. We should be wearing PPE looking after chemical burns. They will need copious washing off as a matter of urgency. The knee there is a classic kneeling in wet cement burn without appropriate PPE. Electrical burns can look fairly innocuous, but they're often far more extensive than the wounds suggest. There's an exit wound on somebody's foot there. What you can't see there is the path it's taken from the patient's hand and the damage it's done on the way through. And you can understand why these patients need cardiac monitoring at very high risk of arrhythmias. So we usually get a pre-alert with big burns coming into ED, and we can often get some useful history at this point. So where did it happen? What was burning? Were there any other accelerants or chemicals involved? Was it an enclosed space? Was the patient trapped? And how long were they there for? And that will dictate what you should be doing in terms of PPE, thinking about preparing to assess for an inhalational injury, and thinking about the more distal effects of burns like carboxyhemoglobin and cyanide poisoning. These injuries, when they do land in ED, are very striking, and that can be distracting, but these are trauma patients, and we should just be following trauma life support guidelines, at least initially. Seek to rule out other injuries, stabilize the patient, get as much history as you can. But for the sake of simplicity, from here, let's assume we're just talking about major burns. So the main thing you're going to be asked to do as the on-call team in QMC is to assess for inhalational injury. Now, when we're talking about inhalational injury, we're talking about three things. That is a thermal injury, a chemical injury, and a more distal toxic injury. The trachea rather is a major heat sink and incredibly effective one. So purely thermal injury is typically limited above the carina, but it can result in very rapidly progressive swelling. If you're seeing damage below the carina, you're probably looking at chemical damage because of inhaled products of combustion which dissolve into the respiratory tract mucosa. You get various noxious substances produced which cause direct tissue injury, and that can be the entire respiratory tract. And then you see the more distal effects of things like hydrogen cyanide and carboxyhemoglobin with tissue hypoxia and more widespread organ dysfunction. So in terms of assessing the airway, what are you looking for? Well, it's all the things that you learnt on ETLS or ATLS. Hoarse voice, carbonaceous sputum, obvious burns in the nose or mouth. Look out for circumferential or semi-circumferential neck burns. They can also indicate a potential airway at risk. And obviously your patient that's got increased worse of breathing, distress or stridor. I've put singed nasal and facial hair there in brackets because although it's common to see that with an inhalational injury, if you do see it, it doesn't necessarily guarantee you've got an inhalational injury. If you've got a flash burn across the face, for example, you can get lots of extensive singeing of hair, but nothing deeper down. So what should you do? Well, if you're in any doubt, just put a tube in the patient. But often you do have a little bit of time to assess the patient in a little bit more detail. And this is where that pre-alert from ED comes into play. If you can, and you've got the skills to do it, a quick nasendoscopy with an intubating bronchoscope is very helpful. We can take some photos via the Nerve Center app, which are very useful for the Burns MDT at a later stage. Please do an arterial blood gas, don't do a venous one. We need to know what the carboxyhemoglobin is, lactate, AA gradients, and measured versus predicted CO2 can give you an idea of how well a patient's coping with any potential acidosis and whether they're getting fatigued or not. A chest X-ray is helpful, but bear in mind that a normal result does not rule out any inhalational injury. But as I say, if you're in any doubt, just put a tube in. No one will criticize you for intubating these patients early. If you are intubating, please expect difficulty and get help. Get the most senior person on site to come and do this, or at least be with you for it. Brief your team on plan A through D, potentially mark the cricothyroid membrane. Use a video laryngoscope first off. Again, you can get some useful pictures which will help us at a later stage. And please place the biggest tube you possibly can, at least a size 8. We cannot get the wide therapeutic bronchoscopes through a size 7 tube. They completely block it and prevent any ventilation, and these patients may well need multiple bronchoscopies in the coming days. That tube should be uncut, and please note the depth at the teeth or the gums. Never note it at the lips. The lips are going to swell. Potentially that's going to lead you to falsely reassure you that the tube's in the right place when actually it's on its way out. Eyes are probably the most effective way of securing the tube. You can use tape onto non-burned skin, but with a tie it's more easy to see what the centimetre markings than it is with a lot of elastoplast around the end of the tape. You're going to have to reassess the depth of that tube very frequently, at least every 30 minutes. Please, please, please place an NG tube as early as you can as well. It gets impossible a few hours in when the patients are extremely swollen. In terms of ventilation, keep them on 100% until you are sure their carboxyhemoglobin levels are low. And the sort of consensus across the MDT here in Nottingham is about 2 hours after the measured carboxyhemoglobin is less than 6%. Why? Well, the British Burns Association are still saying less than 6%, you can come off 100% oxygen. A lot of international guidelines have dropped that to 2 or 3%, and I suspect the BBA will follow that in the coming years. Also, our blood gas analyzers are not particularly accurate with low levels of carboxyhemoglobin. We felt that 2 hours after you're measured is less than 6 should be then a very safe level, even with our the caveats with our analyzers locally. Ventilation should be your standard low tidal volume targets. Don't worry about the CO2 in these patients, assuming there's no contraindication to not worrying about the CO2 like pregnancy or head injury. Keep them head up if you possibly can, and go back and assess that tube position frequently. Titrate your ventilation to ABGs, and then get the bronchoscope out and have a look at the extent and severity of any inhalational injury. And this is what you might see. So normal carina there in picture A, a little bit of carbonaceous sputum in B, through to an inflamed airway with more distal deposits in C. Quite a pale airway there in D. This is extensive chemical injuries as a thermal injury. And then in E there you're seeing sloughing off mucosa, which is going to block the airway and need frequent bronchoscopy, usually multiple times a day, to clear out. The cutaneous burn assessment then is done using the London Browder chart. So this is taken directly from our local one here in Nottingham. We should be ignoring simple erythema and looking merely at partial and full thickness skin loss. But don't worry too much, we don't have to do this. The burns and plastics registrars are very good at this, and they will be in ED with you looking at these burns. You should get a reasonably accurate estimate of the total body surface area percentage then, at which point you can see whether or not you're dealing with a major resus burn, fluid resuscitation. You'll have an idea of the mortality likely from this burn, any need for emergency surgery, and usually some form of temporary coverings in place at that point, frequently something like cling film. So what's a major resus burn? Well, in an adult, that's more than 15% total body surface area. It is slightly less in children, but I'm focusing on adults here. The burns and plastics registrars are great and will work out the fluid resuscitation for you usually, and will often, if you ask them nicely, prescribe everything for you too. We just need to make sure that all the fluid we're giving to these patients is warmed. We initially start with the Parkland formula, which is your percentage body surface area times 2 to 3 mils times your actual body weight in kilos, and that gives you the first 24 hours worth of Hartmann's or plasma light, half of which we should be giving in the first 8 hours from the time of injury. But we don't do the second half of Parkland. Instead, we switch to the Muir-Barkley formula, which is using dilute human albumin solution. There is some evidence that using early colloid is beneficial in major burns patients. So this is how the fluid resuscitation regime looks here in Nottingham, starting with Parkland and then moving on to Muir-Barkley. But as I say, don't worry too much about that. It will be worked out for you. In terms of predicting mortality, it's the modified Bowes score, which is your age plus your percentage burned plus 17% if you're dealing with a significant inhalational injury as well. But as a testament to how good we're getting at looking after burns patients, up to 150% predicted mortality is actually considered survivable. And certainly we've had a few people with more than 100% predicted mortality here in Nottingham survive and go home in the last year. Emergency surgery, well, really this is escherotomy or escharotomy. So you can see here in the top two pictures, this lady's got full thickness burns across her torso. See that waxy, leathery looking skin, very pale, and these burns are going to restrict ventilation. So it's a fairly blunt tool, an escharotomy, to try and open up some space for the subcutaneous tissues to swell and the skin to contract. We also do it for circumferential burns. We'll compromise distal blood supply, and you can see that down the inside of this patient's leg as well. Again, it's done in theatre by the burns and plastics team, and it's only going down to the fatty tissue. We're not getting down to muscle here. Anaesthesia for these operations, they're almost certainly going to be intubated. Ventilation, as we've talked about before. There's an obligation on us at this point to continue with that fluid resuscitation team, make sure fluids are warmed. Bleeding with escharotomy is not usually particularly severe, but if you are dealing with bleeding problems and there's no contraindication like impending DIC, then tranexamic acid may well be appropriate. I'll come back to the choice of anaesthetic in a bit. That's slightly contentious, or a little less contentious than it used to be. And try and keep your patients as warm as you possibly can be. Now, it's very difficult to do that with forced air warmers when you're exposing such large areas of the patient. So you're going to need to warm up theatre as much as you can. Now, at Queen's, you can get to about 29, 30 degrees in theatre. At the city, we can get much higher in theatre too. There's no need usually for prophylactic antibiotics for these patients. They're almost certainly then going to go to critical care. Now, ideally, that would be at the city campus if it's an isolated burn. All the standard safety checks prior to transferring the patient apply. Bear in mind that whoever's in the back of the ambulance is going to need to continue with that fluid resuscitation and try and keep the patient warm, which on a day like today is fairly straightforward. In the depths of winter can be extremely difficult in the back of an ambulance. And from there, the whole MDT will be involved in planning further intervention. I'll just touch briefly on critical care. They will typically then complete the fluid resuscitation for these patients. They'll be titrating further fluids, vasopressors and inotropes to indicators of end organ function. And we don't have a lot of those. We've just got urine output and lactate really. Cardiac output monitors are useful. Urine output target for children is of course higher. They also find themselves quite frequently treating fluid overloads. There's often a slight tendency to overestimate the percentage body surface area when in ED, and also be a little bit generous with fluid in ED as well. So it's not unusual in that first week to be giving the patients diuretics or even renal replacement therapy to pull fluid out of them. There will be a need quite frequently to repeat bronchoscopy for serial assessment and clear out sloughy mucosa as well. That can be multiple times per day. Inhalational injuries largely treated in a supportive way, although nebulizers with phenacetylcysteine, heparin, saline can help clear out the sloughy mucosa. Burns creates a huge hypermetabolic state, and the patients can become incredibly hot, actually. So active cooling can be required within critical care as well. We like to start feeding for our burns patients extremely early, and the dietitians will be involved very quickly with an NG feeding regime. They may ask for an NGA tube if frequent trips to theatre are planned. The physio and occupational therapist will obviously be involved, not just for the chest, but also for passive movements and splinting, trying to protect against scar contractures and loss of joint function. Cooling techniques, well, the simple things work very well. Cool environments, fans, taking dressings off, a bear hugger on ambience rather than warming the patients. But really, the big thing that can be done at the city campus is the Cool Guard, which is a large intravascular central line, which has 3 lumens on it that work like any other central line, but 2 that circulate cool fluid through these 3 balloons that you can see on the line there. And you can pretty much dial up whatever temperature you want your patient to be, and this device will achieve that for you within about 3 hours. The main trip to theatre is all about excising and or debriding dead burned tissue from patients. You'll also get a very accurate percentage body surface area at that point, when we often end up reducing the injury percentage at this point as well. It's possible, but it's unlikely that we're going to be undertaking skin grafting at that early stage. And so instead, things like skin substitutes are going to go in place instead. Things like EpiProtect, Kerecis BioBrain, BTM, etc. There's lots available on the market. These are a barrier to heat and fluid loss. They're a barrier to infection, which the patients are at huge risk of. And they're usually a biosynthetic cellulose or other animal products. Kerecis is from Icelandic cod. BioBrain is from pig collagen. And the other thing we can do is use allograft, and that is deceased donor skin, although at the most recent National Burns MDT, a bit of a worry about fungal infection from deceased donor skin was brought up. Interestingly, all those centres get their deceased donor skin from the same place in the United States. A lot of these temporary skin substitutes are there to prepare the burned tissue for definitive grafting. You're not going to graft directly onto tendon or joint capsule. These skin substitutes will encourage angiogenesis and provide a nice surface to put skin onto several weeks down the line. The first thing I'd ask my surgeons ahead of one of these operations is, how do you want the patient positioned? Are we going supine, prone, lateral? Are we going to move multiple times during the operation? It's not unusual to start on the front and end up on the back or lateral for these patients. I usually will seek to continue NG or NJ feeding wherever possible, assuming I'm not going to be interfering with the patient's airway at any point. These patients are usually coming from ICU intubated. These patients will have a rough doubling of the caloric needs in those first few weeks and months after a major burn, and we really want to maximize meeting those needs as much as we possibly can for these patients. If we're constantly pausing feed for 6 hours, then they're never going to get to where they need to be. And also, these patients are on huge doses of opioids, so even if you are pausing for 6 hours, I doubt you're going to have an empty stomach. If you do need to interfere with the airway for cuff leak or potentially doing a tracheostomy, pausing the NG feed at the last minute and then aspirating to dryness is certainly how we've been doing tracheostomies in ICU for years. Also have a look at the latest microbiology. There is a burns antibiotic guideline on the intranet, but these patients often pick up some slightly weird and wonderful infections. And so early liaison with microbiology is often very helpful. These patients are obviously going to be intubated. Ventilation, as we've talked about before. The fluid resuscitation is likely complete by this stage, and I'll be quite cautious with giving these patients more fluids. As I say, they're often overloaded at this point. I remember transferring a patient out of ICU to Burns Theatre just a couple of months ago. When I put my hand in behind the lady's head to move her onto the table, my fingers left an imprint due to the edema in her scalp. She was that overloaded. I'll titrate instead to things like urine output and lactate. Bleeding is a problem in this early debridement. The literature suggests about 1 ml per centimetre squared of excised tissue, but if that debridement is delayed by a week to 10 days, bleeding can be more excessive than that. Now, locally, I think it's better than that, actually. Our surgeons are very good at infiltrating with local anaesthetic and adrenaline, and I do believe that really makes a difference. I don't think we're seeing bleeding as excessive as the literature reports here in Nottingham. Tranexamic acids, there's been a big systematic review and meta-analysis within the last few years looking at TXA in major burns. And even though they're a procoagulant state, as long as you haven't got a problem with things like sepsis or DIC, then tranexamic acid can help. It is difficult to estimate blood loss in these patients. We often use a device called a Versajet to blast, if you like, using pressurized saline, the dead burn tissue away. And so weighing swabs and looking at what's in the suction bottle doesn't really help because there's so much saline with that. Instead, serial blood gases or the HemeQ are more useful. The transfusion threshold recommendation is as with other critically ill patients. So I said it was slightly contentious, so with choice of anaesthetic. Now, for any burn operation, if we leave the major ones to the side for a moment, general anaesthesia, neuraxial anaesthesia, and regional techniques all absolutely have their place. But I'd be slightly cautious with regional techniques because the surgeons will typically use a lot of local anaesthetic. And bear in mind that you don't just need to cover the site of the burn, you need to cover the site of the donor if you're grafting as well. GA is often more straightforward. For major burns, really it boils down to a TIVA technique or volatile. Now for small burns, do whatever you want, and there's no problem there. But for major burns, certainly above 15%, there is some evidence to suggest that volatile might be easier for you. Next slide, please. And that's partly because when you're dealing with a major burn, you're dealing with a lot of stuff at the same time, and actually being able to focus on the patient and the manipulation of their physiology whilst not having to worry about drawing up lots of syringes potentially frees you to do other things. But also, understandably, there are significant changes in your pharmacokinetics and pharmacodynamics in patients with major burns, and this absolutely influences your anaesthetic. They are increasingly significant, these changes, with the increasing extent of burn. So if you look at a 20% body surface area burn, the volume of distribution of propofol pretty much doubles. The clearance of propofol will increase threefold, which means our current TCI models are inaccurate in major burns. So you can just titrate to BIS. Well, in major burns, BIS is potentially not accurate. There's been a few studies showing a non-linear relationship to increasing doses of propofol in patients with major burns. It seems to plateau at a mean of about 50. The authors of these papers are not sure why. They do speculate it might be due to muscle relaxant wearing off, but you'd think they'd be looking at whether the patients are adequately relaxed during the operation anyway. Narcotrend, however, has been studied in major burns and has been used safely and seems to be better than BIS. So if we do get Narcotrend across the city campus, I think that will open up TIVA to major burns patients as well. In terms of muscle relaxants, obviously avoid sucks, and avoid sucks probably for several years after these patients have suffered a major burn, if not for the rest of their life. There is a relative resistance to other muscle relaxants though. And again, this is due to a raised volume of distribution and a huge increase in hepatic blood flow and clearance. So your intubating dose isn't going to last 30 minutes, it may only last 10 to 15 minutes. In terms of warming, we typically use the hot dog device, which is an electric blankets underbody warmed mattress with overbody warmed blankets in Theatre 2 at City. I know some other theatres use it as well. It's wipe clean, it's reusable, it's plug and play technology, it's quiet, it's a really useful device and it's very effective. We use a fluid warmer, obviously, and we do warm up theatre. We can achieve more than 37 degrees. We hit 40 a few months ago in Theatre 2 at City, which was pretty brutal. Just for me sitting quietly at the top end, must have been absolutely awful for my surgical colleagues. Subsequent theatre trips then are usually all about skin grafting. All the same considerations exist as before, positioning in particular. Again, we need to ensure our anaesthetic covers the donor sites too. Typically it's thighs, but we've used the back, the flanks, we've even on occasion used the chest to take healthy tissue for donation. The donor sites are likely to be much more painful than the site of original injury because the original injury site has usually lost its nerve supply. And this increases the percentage of body surface area involved here. It increases the metabolic demands on the patient. So they usually are still getting supplemental NG feeding these patients, even if they're down on the burns unit. The skin grafts are at risk for infection, so look out for antibiotics. They're also at risk from hematomas and shearing. So anything we can do to help immobilize a joint, for example, with cast and make sure the patients aren't bleeding under the skin graft will help that skin graft. Look out for what's listed as a graft check or a change of dressing. That can take 3 or 4 hours for a major burn. Analgesia, I don't have anything magical here, I'm afraid. It's the WHO analgesic ladder. These patients should all be on paracetamol. If it's not contraindicated, they should all have a non-steroidal. Ibuprofen usually with a PPI as well. They all get some PRN short-acting opioids. Most of them will end up on a long-acting opioid as well. We do have access to Targanact, which is oxycodone with naloxone in the burns unit, particularly useful for the elderly patient population. Whether or not it makes a big difference in bowel opening, the literature is not entirely clear, because a lot of the trials with Targanact compared it against oxycodone without laxatives. But the nurses will tell you that the elderly patients are less confused with Targanact than they are with Longtec. I would absolutely consider regular ketamine for patients. Not just is it opioid sparing, but obviously it's useful in hyperalgesia and wind-up phenomenon as well, as being a great painkiller in its own right. Laxatives and antiemetics for everybody, especially if you're putting somebody on regular ondansetron. It's very constipating. Make sure they're on a stimulant laxative. Pregabalin, duloxetine, and amitriptyline are all still considered first line for neuropathic elements of pain by NICE, but I know that the chronic pain team are favouring duloxetine at the moment over pregabalin after some unfortunate cases of deliberate self-harm with pregabalin that the coroner has been quite critical of. We've also recently started using Penthrox, methoxyfluorine. I know it's already in use pre-hospital ED and I think in major trauma as well. It's very rapid onset and offset inhaler. If you take every breath through the Penthrox whistle, it will last about 30 minutes. If you're managing to eke it out, it will probably last about an hour. The patients are encouraged to exhale through that activated charcoal chamber on top, so you don't have to worry about the local environment getting contaminated with Penthrox. The product information suggests we should be avoiding sevoflurane for 24 hours after exposure to Penthrox due to worries about hepatic and renal toxicity. And as you can see there, it's potentially more environmentally friendly than nitrous. The other way of debriding burns is chemically, and it's Nexobrid is the chemical that we use to do that. It's derived from pineapple stems, and it will dissolve dead burned tissue whilst preserving healthy tissue. It's applied, you wait roughly 4 hours, and then the whole thing is scraped off. It's a bit quicker for debriding and healing times, fewer operations, patients stay in hospital less time. There's less cases of sepsis, there's less bleeding, there's less blood transfusion. But if you've ever eaten a pineapple with a slight cut-in or ulcer in your mouth, you'll know it's incredibly painful. And we haven't really solved this just yet in terms of what to do for these patients. Regional techniques, neuraxial techniques make great sense. They may need an intravenous PCA. In theory, I suppose you could seek to admit the patient to ICU, but realistically, with the pressures on the ICU bed state these days, that's only going to happen if the patient's already there. And methoxyfluorine may well have a role to play here. You can have 2 inhalers a day with Penthrox. So in terms of rehabilitation from here, this is where the physios and the occupational therapists will really take over to seek to maximize function. They'll also get heavily involved in scar therapy with things like moisturizers and massage. Laser is available for adults in Birmingham. We're hoping to bring it into Nottingham, especially with the rehab centre opening down near Loughborough soon. And obviously the mental health support is critical at this stage. We do have an embedded psychologist within our MDT, Dr. Laura Shepherd. These major burns patients are followed up for at least a year, frequently an awful lot longer. And they have access to other things as well. So burn camps where they can go away with their family, with their therapists, and spend some time with other patients that have suffered major burns. There's often an opportunity to go swimming, which they're very self-conscious about, and try and get some normality back into their lives. The outpatient work then, again, it's an MDT, and we're involved from the anaesthetic side because of chronic pain problems, which is very common in patients with major burns patients. Debilitating chronic itch, which is incredibly common and very long lasting for patients. PTSD is a big issue, as is anxiety and depression. But one of the surgical involvement here is often around scar revision. And this typically happens at least a year, frequently many years post-burn. You can see that the top 2 photos there, somebody with terrible scar contractures in the axilla, they can barely get to 45 degrees. And this is the kind of operation that will be done to excise that scar. And that looks like skin substitute that's gone in place there rather than skin graft at this stage. The long term is not great for these patients. The longest study for following up major adult burns patients lasted 3 years. They ran out of funding at 3 years to continue further, but these patients were not back to normal. They still had increased baseline cortisol level as well as increased inflammatory markers at 3 years. They've got a reduced VO2 max compared with age-matched controls. They've still got cardiac dysfunction, in particular diastolic dysfunction. And they've got an elevated baseline heart rate and a reduced maximal heart rate. In other words, these patients have aged, and they've aged quite significantly as a result of their major burn. They're 2.5 times more likely to die in the 10 years following a major burn than matched controls. And a lot of that is down to cancer. We talked about risk factors for major burns, including alcohol and smoking. So unsurprisingly, lung and upper GI cancers are quite common in patients who've suffered a major burn, but it's all types of cancer that are increased following a major burn. On that happy note then, if you're interested in more information, then I direct you to a few of our local guidelines. The inhalational one's just been rewritten. The burns analgesia guideline we're probably going to look at rewriting when we come to the end of our trial period with Penthrox. And there's a very good burns guideline for critical care as well. The British Burns Association run the Emergency Management of Severe Burns course. That runs several times a year. And if you're interested, there's a joint BBA and International Society for Burns Injuries conference in Birmingham this year in August. Thank you very much.